Welcome. This is the fourth webinar in our series entitled Our Daughters, Our Future, an educational series exploring girls' mental health and wellness. We are offering this series from Gateways because we recognize that mental illness and challenges to children's social emotional health are as much a barrier to learning as more traditional disabilities like dyslexia or ADHD. We also recognize that too often mental illness is something that people, especially in the Jewish community, do not like to talk about. There is a stigma attached, and mental illness should be kept quiet. But we believe that the more people understand what mental illness is and how we all can play a role in supporting our young people, the better off those who are suffering will be. And this is ultimately why we are running this series. First, to raise awareness and reduce the stigma around mental illness and our children's mental health. And second, to give us all some insight into strategies we can use to support our young people. Today's webinar is focused on self-harm, and we're going to learn along with Dr. Ashley Warhol from the Devereux Advanced Behavioral Health. And we'll also hear the lived experience from Abby Scully. And in a moment, I'm going to introduce Rachel Shine, who's the director of this series, to introduce more fully our featured presenters tonight. Before I do so, I just want to thank the Miriam Fund of Boston's Combined Jewish Philanthropies for sponsoring this series. The Miriam Fund is committed to creating a world that expands opportunity for women and girls, and Gateways is committed through our work, and in particular this series, to making life for girls and young women in our community a little better. And with that, let me introduce Dr. Rachel Shine.
Thanks, David. Just a couple of notes for everybody as we begin. If you can use the chat feature and the Q&A feature to ask us questions as we go along, I will be moderating, and I'm happy to field your questions and interject and ask the panelists. With that being said, it is a great privilege to be able to introduce our two presenters this evening. Our first presenter is Abby, or Abigail Scully. Abby is a 16-year-old sophomore, and she goes to Northeast High School, and she is joining us from Louisiana. And our presenter is Dr. Ashley Warhol, who I have had the privilege of working with for the past 8 years. Dr. Warhol is a clinical psychologist and the director of clinical services and internship training at Devereux, Massachusetts and Rhode Island. In this position, she oversees the clinical services for a population of about 160 youth with complex mental and behavioral health difficulties and autism, as well as our internship training program. Dr. Warhol received her doctorate in clinical psychology from the Illinois School of Professional Psychology, and she trains nationally on issues regarding best practices for treating LGBTQ youth, as well as major mental illness, self-injury, and dialectical behavior therapy. Dr. Warhol is also an adjunct professor at Becker College and Assumption University. So that being said, we are going to start with Abby sharing her story.
Hi, so I am Abby Scully. Like Miss Rachel said, I'm a 16-year-old sophomore from North Shore High School in Slidell, Louisiana, and I'm here to talk a little bit about my journey with mental illness and kind of how I've gotten to where I am. So, I guess let's start at the beginning. So, I am currently a mental health advocate, and I want to tell you why, because I think it is so important, because mental illness is not talked about enough, especially self-harm, which I'm here to talk about today, which is a big part of my journey and how I've become the person that I am today. So in the seventh grade, I endured a sexual assault. So that took a big toll on me and my confidence, and a big toll on the relationships of me and family and friends, of course. So that was a big, big challenge. And it took a really long time before I ever reached out for help or told anyone, especially my mom. So she did not actually find out until 2 years later. So, in the span of those 2 years was when my journey with self injury hit, I guess you could say, a peak. Um, Self harming is not talked about enough at all. It's a very taboo subject, and it's still very unknown. There's a lot of different ideas about it, and it's really difficult to just have this one idea about it because it varies for every single person. So for me, self-harming was my way to cope with my trauma. It became my outlet. For a while, for a couple months, it was as if I didn't understand why I had endured what I did. So instead of reaching out and seeking for help, I decided that it was my fault because I had kind of put myself in that position being a cheerleader at my junior high. And so I started self harming. I started cutting in the seventh grade. And that went on until my
You're going
freshman
to
year of
see
high
her,
school.
16 years old, Louisiana.
So that went on until my freshman year of high school. And that was, I think that's the most difficult part about my journey is overcoming self-harm because it was so unheard of for me at least. No one ever talked about it. And if anyone that I had known had ever taken part in it, it definitely was unknown to me. So I was really scared and I had no idea why I felt the need to do it. There was just this relief that I got from doing it. So instead of actually dealing with the way that I felt, the guilt and the stress and just the pain from the trauma, I took it out on myself. So cutting became my outlet, like I said, and when my parents found out, it was really hard. And it definitely took a toll on my relationships with other adults, more so than kids. For instance, like teachers, faculty members at school that I had known my entire life, because Slidell is a tiny, tiny city. Everybody is family. So my faculty at my junior high, they were really worried. And the first time that a teacher, per se, ever noticed any form of cutting or like picking, she was super, super upset, but she handled it in probably the best way possible. And I'm very, very grateful for her. She kind of pulled me aside and she talked to me, and we kind of figured things out because at this point, I was already in counseling, working on certain things. So there was only so much she could do as far as tell administration or call my mom. So that was really hard, especially since a lot of my teachers didn't notice. One of my teachers did out of seven. So that was kind of eye opening for me, even in the seventh grade. I was kind of still naive back then, but it's really eye opening to look at now that, I spent 7 hours a day with these teachers and only one of them noticed. And I really hope that that will change in the future for other kids because it's really hard to know how you wish someone would have reacted because you can't go back and change the past of how someone did react to you, but you can tell people what you need. Like that is the biggest thing is you need to reach out and explain what you need to help you overcome it. So I know a really big part of what I needed when I was self-harming was I needed my space. Me and my mom, we kind of butt heads a lot because she is such a touchy person. She likes to give hugs and she likes to know everything that's going on in my life, which is really amazing sometimes. And other times I'm like, okay, I definitely need you to back up and give me a day by myself. So the biggest thing for us was communication with each other. We had to figure out, okay, so I need a day's break. Like I need you to not, breathe down my neck over this because I'll figure it out on my own eventually. So that was a big struggle for us. Probably it still is. Even though I don't, partake in self-harm anymore, I've overcome that journey. It just follows me wherever I go. It's really a blessing to be talking about it today. And it's just such a big problem that I really hope I can be a part of changing in the future. And yeah.
Wonderful. Thank you so much, Abby, for sharing your story with us. And welcome, Dr. Warhol.
Thank you, Dr. Shine. Good evening, everyone. I want to thank all of you for taking the time out of your busy schedules to come and hear this, this presentation on a very important topic. So as Dr. Shine mentioned, I am Dr. Ashley Warhol. My pronouns are she, her, hers. And I will be taking you through a webinar, hopefully one that is full of information and useful tools for you on self-injury. The goal is to have all of you understand the risks and the signs and also learn how to promote resilience in our young youth today. Just a quick disclaimer, I have put examples of self-injury into some of these slides, not to make people uncomfortable or to put a shock factor, but simply because I think it's important that you see some of the examples that we're talking about. So if you do happen to be a teacher or a parent and you're looking for signs of self-harm, that you have a couple of examples of what you might be looking for. I'd like to start with sharing a story about really a case vignette about a 16-year-old youth that we're going to come back to at the very end, but just to kind of set the stage of another example of a 16-year-old girl who struggled with self-harm. Abby was so brave to be able to share her story, and I'm so thankful that she did. And her story is just one of many. And so this 16-year-old girl is a white cisgender female, so female identified, assigned sex female at birth. She had no history of sexual abuse. She was described by others as outgoing, energetic, friendly, and a natural-born leader. She did have experiences of emotional abuse from both of her parents, and corporal punishment was something that her father used for discipline for both her and her brother. The family is intact, so the parents are married, and the parents were involved in a number of community-based organizations. So the father was a coach for the sports teams for both the 16-year-old female and her brother. The mother was active in the church, and the family identifies as middle to upper middle class. This youth had a recent diagnosis of major depressive disorder. She had one inpatient hospitalization as a result of 2 suicide attempts. So she had attempted to strangle herself and also overdosed on medication. It was during her inpatient hospitalization that she actually learned about self-harming from other clients on the unit. So self-injury, self-harming was not something that was in the vernacular of this particular youth until this hospitalization occurred. So following discharge from inpatient, that youth started to engage in cutting and carving behaviors daily. Where this youth was cutting and carving was done on the upper quad or thigh area so that they could be covered at all times. And this youth was a sports player and knew exactly where her uniform would fall so that the cuts and the carves could be covered and people wouldn't know. And what the youth reported using is a sharp tool that's attached to a pair of nail clippers. So if you can imagine, nail clippers have this kind of little hook thing on it. That's what this youth was using to engage in self-harm with. So the youth was being seen by an outpatient therapist and met several times a week with her guidance counselor at school. Youth hid the self-harming behavior from everyone for approximately 6 months and then first disclosed to her guidance counselor. The youth reported that self-harm was used to cope with feelings of emptiness, stress, and hopelessness. And she also said that she wanted to put something visual to her internal pain. The youth stated that she is ashamed and embarrassed by her self-harming behavior, which often feeds the cycle. So just keep this case vignette in mind as we go through. So to start, it's important that we define what self-harm is. And an official definition would be what we call non-suicidal self-injury, or NSSI. And this is any deliberate or self-inflicted damage of bodily tissue without the intent to die. And that's the really important piece about non-suicidal self-injury or self-harm. The intent of the actual act is not to end their life. It's for some other reason, which we'll talk about in a bit as the webinar goes on. So you'll hear me use a lot of different terms interchangeably during this webinar. So non-suicidal self-injury is also referred to as self-injury, self-injurious behavior, self-harm, self-mutilation, as well as parasuicidal behavior. So just to show a few examples of types of self-harm. So cutting is one of the forms of self-harm that we think about most often. But carving is also a very popular form of self-harm. And if you see the photo in the upper right-hand corner, this is an example of some carving that this particular client did. Words are typically chosen based on the negative narrative that the youth has going on for them. So in this particular example, body image issues or feeling fat was something that was very salient for this client. And so they began to carve those words into their leg in order to remind themselves of the way they think and feel about themselves. Burning is also something that is considered self-harm. So whether folks are burning with lit cigarettes or curling irons or hair straighteners, these are just some of the ways. There are also some teens who will create burns using salt and ice cubes. So what they'll do is sprinkle salt on their forearm, for example, and then rub cold ice cubes over the salt very quickly, and it will create a burn on the skin because of the friction and the chemical reaction that's happening. So we tend to see that, or at least I've seen it in my clinical practice a little bit more, particularly in a residential setting where access to means for self-harm is a little bit tricky for them. Scratching is also a form of self-harm. It tends to be what we consider more superficial, so it's on the surface and not necessarily as severe as cutting. We also see head banging or punching the self in the head or on other parts of their body. Hair pulling as well. A newer form of self-harm that we've been seeing in clinical practice is swallowing harmful objects, again, with the intent to harm themselves. So these things could be swallowing batteries or shards of glass or staples or nails or anything that could be potentially dangerous, but the intent is not to die from that. It's just to create some form of harm. And then also restricted eating and purging. And I put stars next to these because you have to be very careful when you're conceptualizing restricted eating and purging in the form of self-harm versus what we might see in an eating disorder. There are teens that will use food restriction or purging with the intent to harm themselves. Their gain is not to lose weight or maintain weight. And that's really the type of self-harm that we're talking about here, where the true gain or the true goal is to manage weight. That would be more of an eating disorder. So I want to talk briefly just about degrees of intensity, because if you are seeing self-harming behaviors, it's important that you understand when you need to be concerned. Most parents and teachers and even clinical practitioners might say, well, what do you mean most concerned? Isn't this a concerning behavior? Well, yes, of course. It is a coping skill that we want our clients and youth to move away from. But the reality is that the amount of damage and serious damage that can be done varies based on intensity. And so when you hear people talk about superficial self-harm or superficial cuts or scratches, this is really what we consider in clinical practice to be on the surface. It does not require medical attention. It may or may not cause the individual to bleed. So sometimes if they're scratching with their fingernails or, an only semi-sharp object, you might see red marks and some raised skin, but you might not see bleeding. In other superficial scratching, you might see a little bit of blood. But if bleeding results, it's minimal and you can treat it very easily with some antiseptic wipes and some Band-Aids. Moderate self-harm is considered to be more than on the surface. So we're kind of beyond the realm of scratching and just raising the skin, but it likely does not require medical attention. So again, the bodily damage needs a bit more first aid than superficial intensity, but it's something that you can manage at home and don't need to seek medical support. When we get into the realm of severe or significant intensity, this is the degree at which you should really be concerned. This type of self-harm warrants medical attention. Typically, it means that they need stitches or butterfly bandages, sometimes surgery in major cases. And it's at this point that the individual is considered to be at high risk. And when you see severe or significant intensity of self-harming behaviors, as a practitioner, my red flags certainly start to go up for suicide risk, whether or not that was their intent, because the severity and the intensity was severe of the self-harm. They could accidentally do something that could end their life. So even if they're telling me their severe intensity self-harming behavior was not intended to end their life, I still consider them to be at high risk because accidents happen all of the time. So I'm going to talk briefly about risk factors and the biosocial theory. So I'm also going to talk a little bit about DBT later in the webinar, but just to give you kind of a brief look into DBT. DBT is dialectical behavior therapy, and it is probably the most well-known evidence-based treatment for treating self-harming behaviors as well as suicidal behaviors. And in dialectical behavior therapy, the overarching theory has to do with what we call this biosocial theory. And DBT was developed by Marsha Linehan. And her theory is that when we have clients or children or students, we are seeing their dysregulated behavior in front of us. But that behavior has resulted from both biological and environmental factors. So there's this idea called a biological predisposition, which means just naturally, biologically, whether it has to do with genetics or something else, there's typically a slow return to baseline, and people with a biological predisposition to dysregulated behavior become upset very easily. When you couple that with the invalidating environment, that's when you see the dysregulated behavior. And the invalidating environment could be anything from feeling mismatched with the family. So for example, let's say you are let's say I'm a child, I'm a fantastic violin player, but everybody else in my family loves sports and just says to me, Ashley, why do you have to play the violin? Why can't you pick up a basketball and be like the rest of us? That could be an invalidating environment for me, feeling like my interests and talents are not being supported and fostered. It could be something like the expression of emotions not being attended to. So the example I always like to use is the child who comes home from school upset about a disagreement they were in with their friend. And the parent is working away furiously at the computer and says, Johnny, I don't have time to listen to you, go talk to your other parent. And then Johnny becomes a little bit more upset and starts to cry. And as the parent, you're still too busy. And, you've got a lot of things on your plate, but you're still too busy to kind of tend to that. And then Johnny goes in his room and starts to destroy the bedroom. And it's at that point, as the parent, now you're paying attention because Johnny is destroying the bedroom. And so over time, it's that reinforcement of more maladaptive or extreme expressions of emotion that leads to this continued dysregulated behavior. And it's not to say, when I explain this invalidating environment to parents, most times parents are, they are taken back a little bit and say, well, what do you mean? Are you saying I did this? It's my fault? And no, that's not what we're saying at all. And we invalidate each other every day in certain ways. I mean, think about how many times you've been at the dinner table with family or friends and you've been responding to text messages. That's invalidating. You're not giving them your full attention. And so, yes, has there potentially been some invalidation of more adaptive expression of emotion? Potentially. But again, it's a combination of what the child is born with as well as what they're experiencing in the environment. And then last but not least, invalidating environments could be as significant as having experienced abuse. And so the way we think in DBT is that the most invalidating experience a person can have is any form of abuse, whether it's physical, sexual, emotional. But that being said, in order to have dysregulated behavior or this kind of predisposition to dysregulation, you do not have to have experienced abuse. And I think that is what happened very early on when DBT was kind of new on the market, is that there was this assumption that you had to have some traumatic experience and really significant suicidal and parasuicidal behaviors in order to benefit from DBT. And that's just not true. People without a trauma history or any sort of trauma experience can benefit from DBT, and they can also engage in self-harming behaviors. So outside of the biosocial theory, some other risk factors that exist for our teens are just difficulty expressing emotion. Sometimes teens just don't really want to talk, they're kind of quiet. History of trauma, of course. The internet is actually becoming a huge risk factor, particularly around self-harming behaviors. All it takes is a quick Google search on how to self-harm, and there are tons and tons of websites on how to do it, how to hide it, support groups for people who want to self-harm. There's support groups for people who want to stop self-harming as well, but there's a lot of information on the internet at this point about how to engage in self-injurious behaviors undetected. Peer education. I kind of mentioned this in the case vignette at the start. Peers at school might talk to each other. It's not to say that it is peer pressure per se, but our youth are learning from each other constantly. And if one child doesn't know anything about self-harm, but has a friend who has started self-harming and says, wow, this is a really great coping skill for me, that's a risk factor. That now they've been introduced to this new potential coping skill that, again, is maladaptive and unsafe, but something that they might want to try because it works for somebody that they care about and look up to. Lack of support. So this is lack of family support as well as peer support. So teens who have really small groups of friends or really lack trusted adults tend to be more at risk for self-harm. Substance use and abuse also creates risk factors. And then any sort of high stress that the teen is experiencing. And this could be anything from academic performance to financial stress in the family. But increased stress definitely loads into an already difficult time trying to manage emotions. So you're probably wondering why, like why would people self-harm? And there's a number of different reasons. And the reality is that one reason does not fit all. Sometimes it's the only way that a person can express or manage their emotion. They just don't know how to any other way. For others, the actual physical relief and the pain that they're experiencing is what they're after. For others, it's self-punishment. They feel that they have done something wrong or are ashamed about something or feel that they need to punish themselves. And then for, in some cases, like the youth in my case vignette, part of it can be wanting to make something less tangible, tangible. So what people are experiencing internally is really painful. And so sometimes it helps for them to put physical pain to the emotional pain that they're feeling inside. So to see cuts or scratches or burns or what have you is to say, wow, this is tangible, this is real. And if anyone were to see this, they would know exactly how much pain I'm in. And oftentimes what happens is that there's some sort of emotional suffering that's taking place. The person is overloaded with the emotions that they're experiencing at that time. And so the person starts to get really dysregulated, panics, not really sure how they're supposed to manage these really overwhelming feelings. They'll engage in the act of self-harm, whatever their particular choice of self-harm is. There's a temporary relief immediately following the self-harm, but usually what happens is shortly after that, once the temporary relief has worn off, there's a tremendous amount of guilt and shame and grief, and it just feeds the cycle all over again. So now we're back to that point of emotional suffering and emotional overload, and you can see how the cycle just continues and continues. So what I want to impart on all of you today is just some behavioral cues that you can look out for. I think sometimes as parents and providers and teachers, we try to rationalize and explain away all the reasons something is without always looking at the other side of the coin. And so what I do want to say, my caveat to this is if you're seeing any of these behavioral cues with your children or your students or your clients, you don't need to automatically assume, oh, self-harm is happening here. But these are things that you might want to keep in mind and then think about asking some questions. So if you notice that you've got a youth wearing long sleeves or pants in the summer or on warm days, that's pretty atypical. So you have to start to wonder, are they trying to hide something? If they're spending long periods of time in the bathroom and it's not typical behavior, I mean, I work with teens, I get it, like sometimes an hour in the bathroom getting themselves all primped and proper, is not a thing. That's just their regular routine. But if you've got a teen who typically takes a 20-minute shower and they're completely out of the bathroom in 30 minutes, and now they're spending like an hour and a half in the bathroom, you might want to start to question why that is. Bloody tissues or Band-Aids in the trash can. So if you find yourself emptying the trash on a weekly basis and you notice like, wow, there's a lot of Band-Aids or bloody tissues in here, that might be something that you want to follow up on. Any sort of spots of blood on clothing. So if you're still doing your kids' laundry, it's a great way to kind of keep tabs on any potential self-harming behaviors. Any sudden or more significant withdrawal or isolation could be indicative of something going on. If you're noticing any bruises on parts of the body, whether it's legs or on the face or on the arms that really your child can't explain or you don't really know where they came from, it's worth following up on. And a big one is, as you're picking up your child's room or, cleaning the house a little bit, if you start to find little broken pieces of hard plastic or glass or paper clips that are, no longer in the shape of a paper clip, they're kind of bent in different ways. Again, it might not be anything, but you want to start wondering like, hey, what are all these tiny broken pieces of glass or hard plastic or safety pins that are around the house. It's just something you might want to follow up on. And then, of course, if there's any changes in eating patterns, and again, this kind of goes back to those caveats that I made at the start. Restricted eating and purging behaviors may be a sign of self-harm, but it also may be a sign of an eating disorder. So you definitely want to talk with a professional about kind of weeding those two out. All right, so I'm going to launch into some myths versus facts, because there are a lot of myths that exist out in the world, and I would love to just kind of combat that. And so the first myth is that self-harm is a suicide attempt. And the reality is it's not. It's not always a suicide attempt. Many people engage in self-harm for a variety of reasons, but not with the intent to die. For a lot of people, the goal is just temporary relief from really overwhelming emotions. Not that they want to permanently end their life. They want a temporary relief from something that's very, very uncomfortable for them, but they're future oriented. They have plans, long-term plans for their life. So it's not considered a suicide attempt. That being said, as I mentioned in the intensity slide, people who self-harm are at an increased risk of suicide. And so we're looking at up to 5 times more likely to think about suicide and up to 9 times more likely to act on it. So self-harm, while not a suicide attempt, can be a red flag for suicide. So you always, if your child is seeing a provider, you always want to make sure that that provider is following up on any sort of suicidal ideation or plans to engage in suicidal behavior. And there's ways that you can ask those parents those questions as parents as well.
Ashley, we have a question for you.
Okay.
So somebody wants to know, what do you say to parents who feel that inpatient treatment is to be avoided because of the other patients, like you had referred to before, who can introduce self-harm or other more frightening behaviors? So how would you talk to a parent about that?
Sure. That's a really great question. And as a provider, I always want to weigh risk versus benefit. And to be honest, I will roll the dice with self-harm more often than not. If I can keep a child out of the hospital and keep them safe in their home, that is always my preference. That being said, it is a tremendous amount, or it can be a tremendous amount of pressure and stress on parents who are really responsible for maintaining their child's safety in the home while we manage self-harming behaviors. And so I really engage parents in a pros and cons discussion around what is best for the child as well as what is best for the family. I think inpatient hospitalization can be incredibly helpful. That being said, it is short-term and it is acute, and it should be treated as such. This is not a place where your child is going to get long-term treatment around their self-harming behaviors, but it is a place for them to be able to go to be kept contained and safe if you feel like you can't do that at home as a parent, or that your child can't keep themselves safe enough at home. And so, again, there are benefits, especially if your child needs to be started on medications. They can do that there safely. And again, it's a sterile environment, and so they can really be kept away from things that will harm them in the moment. The reality being that it's, again, short-term, it's acute, and it's not going to address the long-term behaviors of self-harm. That being said, if the client's old enough, I also engage them with the parents in part of the conversation on what makes the most sense. And if I can get a really solid skills and safety plan with the teen and the parent, I'm comfortable not having them inpatient hospitalized. But again, it's always what works best for the family, because sometimes parents can't be home 24 hours a day, or they don't want to lock up all their sharps in their house, and that's okay. That's totally fine. Everybody has their own limits.
Would you also address kind of the shame piece around that for both the parents and the child?
Yes.
And
sure.
how do you broach that conversation?
So I think shame is a very interesting thing. I think shame, my hope is that this webinar is going to help people feel more comfortable talking about it. Mental health issues are more widespread than people even acknowledge. And so part of the shame on a larger scale, or reducing shame, is just having people being willing to come out and talk about it. That being said, it actually takes a ton of strength for a teen and their family to come together and figure out what is in the best interest of their child. And so even if inpatient is the route that the child needs to go, it takes strength, in my opinion, as a family unit in conjunction with the practitioner to come to that decision, because you've really weighed your pros and cons around what is most important for this child's safety and to keep them alive. And there's really no shame in being strong, in my opinion.
Absolutely. Great. Thank you so much.
Sure. Okay, myth number 2. Self-harm is an attention-seeking behavior. I can tell you one thing, working in residential care, this is how self-harm is conceptualized all the time. We have staff who work with our kids who are trained to work with our kids, but are not clinically trained, with a master's degree in how to be a therapist and all that. So I hear more times than I can count. So-and-so is engaging in self-harm because they're attention seeking. It's attention seeking behavior. Why don't they just ask me for attention? Why do they have to self-harm? And in more cases than not, individuals who self-harm are really ashamed of their behavior and they try to hide it. And so it's not really an attention-seeking behavior because people don't really want to talk about it. They have trouble talking about it with others. They have trouble asking for help, and they're reluctant to share what's going on. Myth 3, cutting is the only form of self-harm. Based on what we've already talked about, we already know this isn't true. It is a common form, but it's not the only type. In adolescents, the most common forms are cutting, scratching, and hitting. And as we already talked about, other forms might include pulling hair, burning the skin, head banging, self-poisoning, things like that. Myth 4, people who self-injure don't feel pain. So in my clinical practice, I've heard many people say, well, how could they possibly self-injure like that? They must not feel pain. Like they must have a really high pain tolerance or, high threshold for pain. And people who engage in self-harm actually do feel pain, but they might experience it differently than those who don't self-harm. So maybe they do have a higher pain tolerance than others. That's not necessarily the case for all. In fact, many people who self-injure find it bearable because it provides relief from emotional pain. So for people who self-injure in that moment, that physical pain overrides the intense emotional pain that they're feeling. And so to them, it's no big deal. It's like, oh, anything is better than what I'm feeling internally. And so the physical pain pales in comparison. For others who have difficulty experiencing any emotions or feelings, self-harm can be a way of feeling something, anything, even if it's pain. Many clients that I've worked with have just been completely empty, devoid of feelings. They don't feel anything. They feel dead inside is what they've described to me. They don't feel joy. They don't feel pain, nothing. And so just to feel something, even if it is pain, they'll engage in self-harm just to know that they're still alive. Because some clients that I've worked with have said, I don't even know if I'm alive. I feel like I'm a shell just walking through this earth and I don't feel anything. And if they self-harm, they cause physical pain and they can at least know for that moment in time that they are alive. And the other reality is that self-harming actually does release some chemicals in the brain that make us feel good. So endorphins, those things that you kind of get high on when you're exercising or eating really, really good food that makes you feel awesome. The same kind of chemicals are at play here when people self-injure. And so it can create a feeling of exhilaration that can be really reinforcing to people who don't get excited by much at all or who don't feel anything. Myth number 5, only adolescents and females engage in self-harm. So the reality is females are the ones that engage in self-harm the most. Adolescence is the group that engages in self-harm the most. That being said, it can occur in any age group. I have worked with kids in my clinical practice who engage in self-harming behavior at 6 and 7 years old. I also know adults in clinical practice and outside of my clinical work who engage in self-harming behavior. So it's not something that's just kind of, the period of adolescence that we need to get them through. It can really happen at any age. In adults, self-harm is often linked to substance use or abuse. So if you're working with adults or you know adults, the reality is if they're using substances, they're at increased risk for self-harm, typically because their inhibitions are down, and they are more likely to have mental health issues and that sort of thing. So self-harm often coincides with that. The last piece is just that self-harm is seen in all gender identities. Again, it's more common in females, but it is not uncommon to see males present with this treatment issue. Where I work at Devereux, we have a number of male-specific programs, and we do treat adolescent males who engage in self-harming behaviors. They engage in burning and cutting and scratching. And the research is showing that, of teens who engage in self-injurious behavior, it could be anywhere from 35 to 50% male in some cases. So it's not just specific to females. So the take home for this is to also keep an eye on your young boys because they are also at risk. Myth number 6, self-harm is rare. Rates are higher than most people think. And some of the data is showing that they could be as high as 17% of adolescents, 13% of early adults, and about 5.5% among adults. And so, if you think as a parent or a teacher or a provider that this is not something that you need to even worry about with your child because it only happens to certain people and isn't and is rare, the data would suggest that maybe that's not true. And so while we don't want you jumping to conclusions and thinking every child is engaging in self-harm, the reality is that we need to be vigilant because it's not as rare as you think. Myth number 7, young people self-harm to fit in. This is often not the goal, although, as I had previously mentioned, they may learn about self-harm from each other. So that is a risk. Self-harm is typically used as a coping mechanism to manage distressing emotions. And a lot of times self-harming is happening not to fit in, but to cope with not fitting in. So many people use self-harm to cope with depression or low self-esteem, body image issues. They may use it to cope with bullying or rejection from other people. And so they're not doing it to be part of the cool kids. They're actually doing it to manage some internal experience that they're having, feeling like they are not part of the cool kids or not part of the group. Myth 8 is people self-harm as a way to manipulate others. This is one of my favorite myths to debunk when I talk with people. It's not intentional manipulation of others. What it likely is a cry for help. Manipulation suggests that they're intentionally using self-harm for secondary gain. That is not typically a common goal of individuals who self-harm. So if you've got a youth who's engaging in self-harm, they might not know how to express their emotions or how to get help or who to get help from. And so showing their self-harm or engaging in self-harm is a way for them to get people to pay attention to them so that they can get the help they need. I'll share a quick story of a client I worked with in residential who did use self-harm as a way to manipulate others. I was doing a family therapy session, and they finished up, and my client wanted a coffee from Dunkin' Donuts, and the parents were working on setting boundaries and, you know, not doing everything their child asked. And so they looked at their child and said, no, like, we're heading home now. You know, we can talk about Dunkin' Donuts next time I come. And my client looked at her parents and said, if you don't get me Dunkin' Donuts right now, I am going to slit my wrists. And that was secondary gain right there. She was not dysregulated when she said it. She wasn't trying to manage any sort of significant, overwhelming emotions in that moment, except the fact that her parents said no. And I used a strategy with her that we use in DBT, which is called extending, which basically makes a mountain out of a molehill kind of thing. And so I looked at my client and said, oh my gosh, I can't even, like, coffee is the last thing on my mind. You're telling me you're going to slit your wrist. We need to get you to the hospital. And so in a way I called her bluff, and she kind of stopped and was like, what are you talking about? Are you nuts? I'm not going to the hospital. Like, I don't even want to hurt myself. And so it was through that experience that I could point out, okay, right, to my client, that you wanted Dunkin' Donuts and you did not effectively communicate getting that, or your disappointment around not getting that. And so that's an example of using it to manipulate others. Most people who engage in self-harming behavior do not do it for some sort of secondary gain. It's usually a cry for help if they are showing others. Myth number 9, all individuals who self-harm have been abused. As I mentioned earlier, having a history of abuse can increase risk around engaging in self-harm, but not all people who self-harm have been abused. There's many other risk factors, many of which include body image issues, low self-esteem, depression, anxiety, other mental health diagnoses, and may also include drug or alcohol abuse.
So this is a good time to, you just, this question relates to what you just said about substance use. So for adults who self-harm as a child and did not receive assistance or work through it, does it ever develop, or is there a high incident rate of substance or alcohol use as a coping mechanism as an adult?
That's a good question, and also a hard question. And I will give the typical psychology answer of it depends. The reality is that, you know, some adults with mental health issues will use substances to self-medicate. So they may use drugs or alcohol versus being on prescription psychotropic medications. For some, their coping mechanism may have moved from self-harming behavior to substance use. It all just depends. So is it possible? Yes. We see people's coping skills change over time, all the time. Sometimes they go from maladaptive to adaptive. Other times they go from maladaptive to another maladaptive, which in this case, cutting to substance abuse might be one of those cases. But there could be reasons that people choose to use substances for coping over self-harm because, you know, as you age, you know, it's a little more socially acceptable to be out at the bar with your friends and having a little bit too much to drink versus showing up to work with fresh cuts on your arms. And so you might shift your coping mechanisms just because of the different environments you're in.
Thanks.
You're welcome. All right, myth number 10, self-harm is just a phase that teens will outgrow. So self-harm is not just a phase, and it's a serious concern that requires intervention. It's not something that as a parent or a teacher or a provider, you just want to sit back and say, well, we're just going to ride this storm out and see what happens. It's serious. It needs intervention. It's not a healthy or adaptive way to manage stress, and it actually increases risk of suicide, as we've already talked about. So the longer and more frequently self-harm occurs, you're increasing your risk of suicidal behavior and the potential for completing suicide. So it's not something we want to just kind of ride out. Self-harm also represents more than just a phase because it's connected with other mental health conditions. It's very rare to have somebody just self-harming for the sake of self-harming. Usually it's connected to either a traumatic event or depression or anxiety or bipolar disorder or borderline personality disorder or substance use. And so you can't just kind of sit back and wait for those things to go away, because those underlying issues that are driving the self-injurious behavior need to be addressed if there's going to be any sort of success.
So, Ashley,
Yes.
we just got a question that asked, what if the teen won't participate in counseling or therapy?
Yes. Many won't. So we actually see this a lot in residential care because they are forced to be there against their will, essentially. But what we try to do is make them part of their treatment. And so if we were doing this on an outpatient basis, I would try to, if you need to try 3 or 4 different therapists to find one that your child is willing to work with, that's what it's going to take. That being said, in order for the child to be successful, they have to want to stop for some reason. And I could do like a 3-day webinar on dialectical behavior therapy and the strategies we use. But one of the things that we do in DBT to get buy-in from resistant clients is to focus on these life worth living goals. So why they get up every morning, what is it? Is it to be a doctor someday? Is it to be on World of Dance? Is, what drives them and motivates them? Like, why do they wake up every day? And if we can get them to a place where they want to participate in getting to whatever that grand goal of theirs is, we can usually get a little bit more buy-in for treatment. And the way I frame it as a DBT practitioner is that I'm not here to force anything on you. I am here to guide you toward that life worth living goal. And I work for you. Like, if you want to be a doctor someday, awesome. I definitely want to get you to be a doctor. And you know what? I've got some really cool tricks in my magic bag that can get you there, because this self-harming behavior, which makes you not be able to go to school, is like really jamming up your plans on becoming a doctor. Because like you kind of got to go to med school for that. And you kind of got to be alive for that. So let me teach you some tricks that I have. And so if you just keep framing it back to this life worth living goal or whatever it is that they want to be when they grow up, it tends to work a little bit better to try to get buy-in. But you really, like, it's about partnering with the child and getting them to feel like you're working with them and for them and not against them. Because teens in general don't want to listen to their parents, right? They're like, oh, you're going to tell me to go turn the light off, so I'm going to leave it on just because I'm a teen. Like, that's what I do. I'm a teen. So the less you try to force something on them and partner with them, I've seen better outcomes.
Yeah, and I think one of the things that I would highlight about what you just said, Ashley, is about that relationship piece. Mm-hmm. If you can get that really dynamic practitioner, that's going to be key, because the relationship that the teen has, they'll want to go see their therapist. They often, as DBT practitioners, people will often say that the positive relationship with the therapist is the most reinforcing thing. So Abby, I don't know if you have anything to say about this, if you want to turn your camera back on, about if you were a teen, and you are a teen, right? But what about if you didn't want to participate in therapy, or what might you say to a friend if they didn't want to participate?
Okay. So I kind of have like personal experience with this because I was very, very, very much against therapy or any sort of help at first, when my mom suggested it. So she ended up, she scheduled us a meeting with my current therapist because we were just very lucky. And the first one that we tried ended up being perfect for us, for me. Um, but I was very much against it. So my mom kind of gave me a break and we let it, we let it go for 2 weeks, and she kind of scheduled a meeting and she checked me out of school and we took it, minute by minute. And she just made sure, she bought me like my favorite drink or something just to kind of get the positive vibes going. And for probably 3 months after I started weekly therapy, I still wasn't really into it. I definitely agree with what Miss Ashley said. Is it's a lot of it goes into the dynamic between counselor, therapist, and client. Like if I didn't want to be there, it was very obvious. And if I wasn't putting in the work, I would leave the session feeling the same way I went into the session feeling. So it took me probably 3 or 4 months to learn that. And once I figured that out, I just instantly, it clicked all of a sudden. And so now I try to make like an affirmation before I go into every session about what do I want to discuss and what do I want to leave feeling, because it's kind of all in the client. You have to want it for yourself. They can only want it for you so much before anything actually happens.
Awesome. Thank you, Abby. That was great. Ashley, you still there?
Yep.
All right.
All right. All right. The last myth is self-injury isn't treatable. It is very treatable, very, very treatable. And evidence-based interventions exist to address this treatment issue. I've mentioned DBT a number of times. You're going to have to hear me talk about it again because I am such a DBT fan. The goal of treatment really is to increase the use of healthier and more adaptive coping skills to manage the stress that they're experiencing. Treatment should also address any underlying issues that serve as triggers for self-harm, as I previously mentioned. So if there are any mental health conditions or social issues going on, you want to make sure that treatment is addressing that.
Ashley.
Yes.
So this is you're gonna talk a little bit about this, but it's related to your last slide also. Somebody wants to know, how does EMDR fit into the self-harm emotion dysregulation picture? And is it a valid form of therapy after residential and several partial hospitalizations?
Well, I'm so glad somebody asked this question, and I will mention kind of other adjunct treatments. I will not pretend that I am EMDR trained because I'm not. But EMDR is typically what we would see as in the DBT world as a stage 2 treatment. So dialectical behavior therapy is considered a stage 1 treatment where we are really trying to get the more life-threatening behaviors under control, so suicidal and self-harming behaviors. And once adaptive coping skills have been developed and we've seen a significant decrease or absence of self-harming or suicidal behavior, we'll move into stage 2 treatment. And that's typically where you'll see EMDR or trauma-focused cognitive behavior therapy. In stage 2 is where you'd start to use some of those adjunct therapies to address kind of the underlying issues that triggered the self-harm to begin with. And yes, EMDR certainly can be used once the life-threatening behaviors have been managed.
Great, thank you so much.
Which is a great segue into clinical treatment for self-harm. That was a great time to ask that question. So if you haven't noticed yet, I love DBT. I eat, sleep, and breathe it. But the reason is that I have studied it for a very long time and I have used it in practice and it works. And there's a lot of research around it working for these very treatment issues. It's evidence-based. And so, of course, I'm going to get on board with that. So dialectical behavior therapy, or DBT, actually uses a long-standing form of therapy, such as cognitive behavior therapy, but blends it with Zen practices. And so there's kind of this mindfulness element that gets one centered with themselves and the world around them, while also teaching skills through a very cognitive behavioral lens. So one of the primary elements of DBT is this idea of a dialectic. And dialectical just means you're able to hold two opposite things true at the same time. And the goal really is to move a client away from all or nothing or black and white thinking. Because it's that all or nothing or black and white thinking that gets clients stuck in this cycle of self-harm. And so if we can get them away from, I never do anything right, I always mess everything up, I'm always a terrible child, those cognitions are what kind of drive the shame piece and the emotional feeling emotionally overwhelmed that leads to self-harm and feeds the cycle. And so in DBT, we use a number of different modalities. So in individual therapy, we address self-harm and other target behaviors directly. So I talked a little bit about the life worth living goal. So in individual therapy, we would work with the client to figure out what they wake up for every morning. And then we would develop what we call a diary card, which is essentially a behavior and emotion tracking system that they have to buy into, which will track their emotions and their target behaviors daily. So let's say they're presenting to treatment for self-injurious behavior. That would definitely go on the diary card, and we would be asking the client to track that every day. And then we would review the diary card in session. And if the client did engage in any self-harming behavior, we would do what we call a behavior chain, which is just really kind of a fancy term for figuring out what triggered it, what led up to the behavior, and how the client felt right after. And we do this to try to pick apart areas that we could have the client learn to intervene with a more skillful practice, or we'll set up different reinforcement or behavioral schedules in order to target some of the things that are keeping this behavior alive. There's also group therapy, which teaches skills for coping with distress, managing emotions, and improving relationships across 5 modules. And so in a group for teens, they are getting the mindfulness module. They're learning distress tolerance, or what we call crisis survival skills. There's also emotion regulation skills, or also known as problem solving skills. In the teen version, there's the walking the middle path module, which is very family oriented and teaches specifically about dialectics and behavior management and changing behaviors. And then the last module is interpersonal effectiveness, or how to keep and maintain healthy relationships. There's also family skills training, which is a DBT group that involves the family members. So the parents are learning the skills along with their children so that they can go ahead and coach and reinforce the skill use at home. And then for those of you working in school settings, there have been DBT groups adapted specifically for school settings. Even though you might not have a huge block of time, or you only got your students like once a week, there are certainly ways that you can integrate DBT skills into a school setting. So other treatments that can be used for self-harm are cognitive behavior therapy. There's also acceptance and commitment therapy, behaviorally based interventions. So you might come up with behavior plans or incentive protocols. Sounds like by Abby's description, maybe there was a little bit of a behavioral intervention there by getting the favorite drink for going to therapy. There's also medication management. And then for trauma, as I mentioned briefly already, we might see the use of trauma-focused cognitive behavior therapy, or EMDR, once they've moved into stage 2 treatment. So for the parents on the webinar, you're probably wondering, like, this is all well and good, but what do I do? Like, this is, new territory for me, or maybe it's not new territory for you, and you are just looking for some additional pointers. So some things that I suggest you do is ask your child directly about self-harm. It can be a really scary thing to ask, but just asking straight out is a great shortcut. And some ways you might ask the question are, always start by highlighting that your child is not in trouble and that you're not angry with them. You can say something like, I've noticed you seem down lately. Sometimes teenagers self-harm to cope. Is this something that you've thought about doing, or have you already done it? You could also say, I've noticed you're wearing long sleeves and it's pretty hot out. Is there something you're trying to hide? Because whatever it is, I'm here to listen and help. While you're asking directly about self-harm, especially if they're endorsing, yes, I have engaged in self-harm, you're going to want to follow that up with a question directly about intent to end their life. So something like, have you ever thought about killing yourself? Do you have a plan? Are you going to follow through with that plan? Assess if they have access to the means to follow through. And even though you are shaking like a leaf on the inside, be nice and strong on the outside. Like you cannot even waver when you're asking these questions. Secure the environment. So you may need to lock up things in the environment that they are using for self-harm just to keep them safe. Make sure you're listening actively and non-judgmentally. Let your child know that they are not alone, that you are there to support them and that you want to get them help. You will want to see the injuries so that you can assess the severity that I talked about at the beginning, because if they need medical attention, you want to make sure that you're addressing that right away. And then one of the most important things I want to impart on you tonight is that remember that relapse is part of recovery. So your child may be self-harming, they may be on a really great track not self-harming, and they might have a slip up, and that's okay. That's all part of the recovery process. The last thing you want to do is treat it like it's a huge disappointment or that they have to start all over again, because that will just instill a sense of shame and embarrassment that they're probably already feeling anyway. Things not to do. I know it's easier said than done, but try not to panic. The more anxious you become, the less likely your child is to talk. Try not to catastrophize or assume the worst. So even if you've got a child wearing long sleeve shirts all summer long, don't catastrophize and automatically think, oh, they're self-harming. Don't punish your child. When I work with parents and they say, oh, I grounded my daughter because she engaged in self-harm, they've already punished themselves through self-harm. They don't need to be grounded or have their Kindle taken away or what have you. They're already feeling punished enough. Also, try not to take it personally or make it about you. I worked with one parent who did some really great work in therapy, in family therapy, but at the start when her daughter would self-harm, her immediate reaction was, why are you doing this to me? I can't, this is embarrassing to me. Do you know how upsetting this is to me? And then, so it created a lot more shame. And then also this dynamic where the client felt like she needed to take care of her mother. And so it actually feeds the cycle. So to the best of your ability, it's not about you. It's really not. It's stuff going on internally for your child, and that they have to try to manage. And all you can do is be a great support to them. And then also remember that it's not your information to disclose to anyone other than professionals working with your child. I know sometimes when, really upsetting information comes to light, some parents are calling the best friend and saying, Sally, did you know about this? Why didn't you tell me about this? And then they're calling the neighbor, and then they're calling, the grandparents and the aunt and all that stuff. Like, it's not something that teens necessarily want broadcasted. If they did, they would have been talking about it long before already. So just, outside of sharing it with the therapist or the counselor, have a conversation with your teen and say, like, who are you comfortable me sharing this with? Can I talk with my best friend so that I have some support? I do know we have some teachers on this webinar, so very similar advice, but if you're a teacher, if a student approaches you and discloses, listen attentively and without judgment. Thank them for trusting you and acknowledge that it's really difficult information to share. Let them know that you want to help, and that you need to contact the guidance counselor. And so if they don't want to go alone, offer to go with them. Say, hey, would it make you more comfortable if I walk down to the counseling office with you? I'm happy to do that. Even if the student asks you not to share, just remember, you're a mandated reporter. Review the limits of confidentiality. That's not a secret you can keep. And it's okay to say, you know what, I care a lot about you, and that's not a secret I'm willing to keep because I want to get you the help you need. How about you come down to the counseling center with me? Things not to do, similar to parents, try not to panic. Sometimes easier said than done. As I previously mentioned, you're a mandated reporter, so don't promise to keep information a secret. And although you're a trusted adult, do not feel that you need to take this on yourself as a professional counselor. The best thing you can do is help the student get the resources that they need.
Ashley, quick question. I think this applies to teachers as well, but how would you suggest that a clinician kind of handle their first experience with a client who is engaging in non-suicidal self-injury or teachers?
Don't panic. That's always the first go-to. Don't panic. If this is your first go, it can be really jarring. And so think of a time where somebody told you something really upsetting and you just kind of like, thank you for sharing that with me. And, you know, you just kind of use your own internal skills to be able to manage that. And if you're in over your head, if you're a new practitioner, contact your supervisor. Just let your client know if you're not even sure how to handle it in the room. Just say, you know what, this is really important, what you just told me, and I want to make sure that I get this right. I'm going to go get my supervisor so that we can have a conversation with you. But I am so glad that you had the courage to tell me about this. And, you know, we're going to get you on the right track. If you don't feel like you have the skills to do it, the worst thing you can do is pretend you have the skills and then say something you probably didn't want to say.
Thank you.
All right, and as parents, you need your own support. This is really challenging stuff. And so remember that it isn't your fault. You can talk with trusted friends and family, especially if you've already run it by your child. Make time for self-care, because caring for a child who engages in self-harm can be really time-consuming and really stressful. So whatever resets your kind of baseline or refills your cup, make sure, I cannot stress how important it is to take care of yourself. You can join support groups. They exist in a lot of local communities. You can seek out self-help literature. So I put a few examples here. Helping Teens Who Cut is a very popular book that parents read and has a lot of really great resources in there. There's also The Parent's Guide to Self-Harm and Healing Self-Injury. These are just a few of the many things that are out there. And then, of course, seek therapy for yourself, because this does take a toll on you as a parent. And so you need the support just as much as your child does.
Ashley, one additional question. So as grandparents who have a grandchild who was just released from several weeks of inpatient therapy, I must admit that it felt very disappointing not to have been told about the situation. Is it so bad for the patient to know that those who love her the most after the parents know about and support her, know about her hospitalization and subsequent treatment?
So it's not so bad. And so the way that I would approach it is this, you know, if there's a need to know amongst family members, that's okay. But I always err on the side of assuming until the client tells me who they want to talk about it with, that we just don't talk about it. So for example, If the parent tells you as the grandparents, this is what happened, we had this inpatient hospitalization, there's been self-harming behaviors, Jenny is not ready to talk with you about it. I think it's important for you to know so that you can support her, but when she's ready, she'll talk with you about it. And then the ball is in Jenny's court, and she will navigate that discussion when she's ready. It's fine for you to know as a trusted family member, but really it's important that the youth is guiding that conversation so that they don't feel embarrassed or ashamed.
Great, thank you.
So promoting resilience. Some strategies are to focus on combating all of those risk factors that we talked about earlier. So substance use, low self-esteem, body image issues, help youth to build mastery. So if there's something that they're interested in, support them in mastering that activity. Get them signed up for, dance classes or social groups or sports teams, whatever is going to make them feel good. Promote and foster positive connections with people and be a positive presence in your child's life. Focusing on body positivity is also really important. And then the last piece of advice is really to teach and guide without judgment. And this kind of goes back to that forcing kids to forcing teens to do anything doesn't usually land super well. So, be there to support them and guide them. And you can still teach kind of the values and all the good things that you want your kids to be in the future when they grow up. But if I go back to my violin example, if they want to play the violin and the rest of the family are sports fanatics, you don't need to judge that. Let them play the violin. Let them be the best violin player that the family has ever seen, because that is what's important for them. Now, the case vignette, if you remember our 16-year-old youth, I did just want to, after hearing all of that, wanted to let you know how things turned out for that youth. So the youth engaged in self-harm behaviors for approximately 1 year. So the teen was about 17 years old when she stopped self-harming. She actually ended self-harming behavior as a result of her own internal motivation and external reinforcers. So one day she just woke up and said, you know what? I don't want to be doing this anymore. She was missing out on social activities and relationships. She went on to complete high school, her bachelor's degree in psychology, and she even got a doctorate in clinical psychology. She did not engage in self-harming behaviors for 20 years, and she became the youngest director of clinical services for a national behavioral health organization and helps youth with the same presenting problems as she had. And if you haven't figured it out by now, it's me. I am the 16-year-old youth with self-harming behaviors, inpatient hospitalization, and went on to be a very happy and successful young adult who no longer engages in self-harming behaviors. And if anyone is looking to contact me or has any questions, this is how you can reach me. But that concludes my presentation. Thank you all for coming out to hear the good word of what I have to say. And I sincerely hope that you have taken some good tidbits home with you tonight.
Thank you, Ashley, and thank you, Abby. So this is a question for both of you, which I actually saved, why I saved it for the end. Somebody would like to know, what do you wish teachers had done when you were self-harming?
So for me, there were a lot of behavioral cues, and nobody even took the time to ask. Separately, at that point in time, I was struggling with significant depression. My grades were slipping. I was sleeping through classes. And because I was a boisterous, outgoing, funny person, I often disrupted the class because I was trying to be the class clown. So the fact that I was sleeping and being quiet was like totally fine for teachers. So they just let me be because finally they had some quiet. And they missed a lot. They missed a lot of behavioral cues. And even when I was out for my inpatient hospitalization, when I came back, it was like nothing had ever happened. And it felt really invalidating to me to not have, while I didn't really want to talk about it, nobody even checked in and asked if I was doing okay. And I just wish that my teachers would have been more open to checking on me as an individual.
Thanks, Ashley. Abby, do you want to answer that question?
Yeah, sure. So I completely agree with everything that she said, except that we are polar opposites. I am the shy, quiet, very keeps myself kind of girl, especially at school. And there was a lot of behavioral cues as well. I was sleeping in and I was late to class, and that never ever happened until 7th grade. My grades were slipping. I was a straight A student since pre-K, and I got my first B in 7th grade, which doesn't seem like much of a difference, but for me it was. And for my teachers, they knew it was a difference because I was the girl that had 105s in every class. And there was a 2-week period where I did not go to school because I just could not get out of my bed. And for me, I completely agree. It was really upsetting that, there was, especially in junior high and high school age, you have so many different teachers. You would hope that 1 out of the 7 that you have would have, caught on, especially the ones that I was closer with, which was always my English teachers. But in the end, I did have one teacher catch on in 7th grade, and she handled it perfectly. She pulled me aside and she did everything that I could have asked her to do. She kept it very quiet, didn't make a disruptance to the class. She reached out for help, but she also understood that I needed a little bit of space because she already knew that I was in counseling and already had the opportunities that I needed. So she was incredible when it comes to checking in and making sure that I knew that someone was there for me and was noticing the signs.
Thank you, Abby. That's so great. So we're going to answer the other questions that have come in, but I did just want to make a few announcements because I know that some people are going to have to jump off. So there is a follow-up session that I'll be doing to answer any questions next Monday. So you will get the link for that tomorrow. If you haven't already signed up, please feel free. We do have our final webinar on trauma in June. And again, thank you to the Miriam Fund for funding this great series and bringing our presenters. And yeah, and thank you so much to Ashley and to Abby. Okay, so I'm just going to, Ashley, can you stop sharing your screen?
Yeah.
So Ashley, we have a question for you. Then I just lost the question. How can you talk to younger children about an older sibling that self-harms in an age-appropriate way?
Oh, good question. So there's actually several children's books out there that talk about self-harm. I think one is called like Why Do We Hurt Ourselves or something. So there, if you just Google children's books on self-harm, you'll get a wealth of resources on people who are really well versed in how to educate people on this. The other thing I would say is just to depending on the child's age, use age appropriate language, but, to say, everybody expresses their emotions a little bit differently. And, if we say, your older sister has this way of expressing her emotions where sometimes she hurts herself on purpose, and that's the way that she gets it out, but she's learning a way to express her emotions without having to do that. And so, explain to them how they can express their emotions without hurting themselves, and just kind of highlight the fact that you and other people are trying to get help for their older sibling to learn how to do the very same thing.
Great, thank you so much. And I think that is all of our questions. Michelle shared a story that she had made a call and the student thanked her later on. So oftentimes that is the case where somebody will thank you for helping them even when you thought initially that they didn't want you to. So please don't be afraid to say something. All right, thank you everybody for joining us tonight, and please fill out the survey that you will receive tomorrow. We will also send the PowerPoint and the recording of the webinar, as well as a resource list. And don't forget to sign up for the small group discussion next week. Thanks.